the mid portion of the second thoracic vertebrae. So that could be important for you to understand when you're looking at an X-ray where you're at, right? So we're through the cervical, we're down into the thoracic. It's also the midpoint of the trachea. Okay, so a couple of things with your suprasternal notch. You're at T2 and you're midway through the trachea. Right? Those are a couple of things that you're going to just understand as far as those are landmarks when you start to look at X-ray. All right. So the diaphragm. We know how the diaphragm works. We know the muscles that are involved with breathing. We'll talk about it just a little bit more in just a moment. The airway. You guys have all seen this before in some form or fashion in the past. All right. So the trachea. 10 to 13 centimeters in length. It has an approximate capacity of about 30 mL. So why is that important? So when we look at a circuit, dead space ventilation starts at a certain point in the circuit. Can anyone tell me where in the circuit dead space ventilation starts?
The level of the terminal bronchiole.
Would we agree it's at the end of the Y? Right? So we have an inspiratory limb, we have a Y piece, we have an expiratory limb.
Oh, I misunderstood.
Once you get to the Y, anything distal to the Y starts your dead space ventilation. All right? So when you look at a circuit, they're corrugated, they're generally collapsed when you take them out of the package. Somebody's going to ask you at some point, so if I increase the length of this corrugation, do I increase my dead space ventilation? No, you don't. Dead space ventilation starts at the Y. All right, once you're distal to the Y. That's why that's important. All right, so this capacity will tell you when you see these volumes when somebody that's spontaneously breathing either with an LMA or an EP tube in, that when these volumes are really low, they may not be ventilating really well, right? Because you have volume between where the Y is down to where you actually exchange and ventilate through the patient. And if this volume that you see come back to you on the ventilator is really low, you may not be ventilating that patient really well. So you may look like the patient is breathing. Oh, there goes my end-tidal goes up, my end-tidal goes down. End-tidal goes up, my end-tidal goes down. But they're not ventilating enough to not be increasing their PaCO2. Right? Does that make sense? Okay. Okay. So bifurcation at the trachea. This is drawing. You guys know that by now. That's important. Okay, you guys are eventually going to be either looking down the bronchoscope yourself or looking at a screen that has the bronchoscope that's going to tell you whether your tube is in place. Is my double lumen tube in the right place? Is my single lumen tube in the right place? Is there obstruction in the airway? What's going on? All right, so the carina splits off into the right and the left main stem. So why is it important to know the angles when you come off of the trachea down to the right and the left? So if I'm going to intubate, when you guys intubate, you're very excited, right? Super duper excited. So when you see cords, tube, just as far as you can put that thing, right? And it's like, I think you're tickling their toes. Right? Clearly, you may be ventilating alveoli completely with this tube. You are that far down with this tube. Let's pull it back just a little, right? Because you get excited. So when you start to see how the anatomy works out, you'll understand why you right main stem intubate people when you put the tube in a little farther. It's all about the angles as it kind of comes off. When we talk about double lumen tubes here in a little bit, I'll kind of explain that a little bit more. When we talk about the distance from the right main stem to the first takeoff with your right upper lobe, and then your takeoff to the left upper lobe, it'll start to kind of make some sense to you. So, between 1 in 250 and 1 in 50 people have this really strange takeoff, where the takeoff to the right upper lobe is not in the right main stem. It's actually in the trachea. All right? So that could be strange if you're dropping the bronchoscope down in there and you're looking at carina, but there's a takeoff before the okay? That's generally heading up to the right upper lobe. It's not frequent, but you may encounter it from time to time. All right, so kind of the airway, right? So right, left. You can see there's a little bit of a shorter distance for your right takeoff, right, to the right upper lobe. So when you're looking down in your bronchoscope and you're looking at the screen, one of the things that is going to tell you your landmarks for am I in the right or the left until you figure out which way is up and which way is down, which way is anterior or posterior by looking, is when you drop into the either the right or left mainstem, the distance before you have that first takeoff, right? So when you have a very quick dropping into one of the main stems and there's a very quick takeoff, you're probably in the right. If you've got to drop down a little further before you see takeoff, now you're probably on the left side, okay? That takes time. I don't know how many of you guys have actually seen a bronchoscope. Seen them, probably everyone's seen them. I mean, who's actually used them to guide something down there? Probably not many of us, right? So it's really important to understand which lobe that you're in, okay? All right, so the trachea, so we're going through the divisions of the airway. Start with trachea, right, left mainstem, bronchioles, terminal, respiratory, alveolar ducts, now alveolar sacs, and alveoli. So standard stuff, you guys know this. Okay. Now, there's lots of names for all of this stuff. All on the quiz. Just kidding. Just kidding, all right? This would be ridiculous to try and learn this, all right? Ridiculous. But it actually does have a name. I'm not going to test you on it. All right, so what is the reason that we have the anatomy that we have? How does this cold air that we're breathing today, this nice crisp cool air, not like kill us once it gets down into our alveoli, right? Well, we warm and humidify that. We do that through the nasal passages, the lower passages, down the trachea, down the main stem through the bronchi. That's all so when that volume of air gets to where it's supposed to go, it's at the appropriate temperature and humidity, okay? So when we look at the divisions, we start at the top, trachea. First division is our right and left main stem. There's 23 divisions or generations. Sometimes you'll read in literature generations. That's a bifurcation. Next bifurcation, next bifurcation, next bifurcation. Before you get to the alveoli. So 23 from the top to the bottom. Trachea to alveoli. 23. Both sides. Yeah, both sides. So why is that important? Well, when you get to generation 17 and beyond, you actually start having ventilation across the membrane. All right. So approximately double the number of airways exist with each generation. So like I said, it bifurcates, it bifurcates, it bifurcates, it bifurcates, right? So you're just doubling your number every time. The alveolar sacs each roughly contains 17 individual alveoli. If you were to spread that out, just super thin material, right? It's a very thin tissue. Spread that out, it's about between half and a full football field in each of us, right? Not all of us combined, each of us. That's a lot. Like if you think of the surface area of that, that's a tremendous amount of surface area. So these are really thin membranes. This is really thin tissue. Usually single cell at that point, it's very, very thin tissue. But that's a lot of surface area that you're moving volume, oxygen, and carbon dioxide across. And then when we're involved, our vapors go across that. So we start at the top of this kind of ciliated columnar, then we move to cuboidal, then we kind of go to this flat alveolar epithelium. So why do we have these cilia? Why is our airway designed the way it is? Well, in our upper airway, in our nose, in our trachea, in our right mainstem bronchus, we're filtering a lot of stuff as we come in, right? When you are in a dark room, you have one light on, right? See all that stuff? It's like glitter, but it's skin, cat dander, right? Mold. Oh, it's great. Yes. O2 cilia. Get that shit out of me, right? Because you're breathing that stuff, all right? You can't see it, but you're breathing. So that stuff's got to get out of there somehow. You're sucking it all in or pulling it all into your body, and your body's like, I don't want that. I'm trying to get rid of that, right? So it gets rid of it. So that's how we're designed that way. So gas exchange occurs only across the flat epithelium, if that makes sense, because then we're a super thin layer at that point, all right? That begins generation 17 through 19. So, as you can see, we start trachea, your generations, right? So as these generations, they each have different names. So once you get down to 17, you get into these respiratory bronchioles, you'll see that you can have an alveolar sac there, or an individual alveoli there, right? So it's very thin, single layer, and you're actually able to ventilate through there. Once you get all the way down to the alveolar sacs, that's when you have that kind of classic look about this big alveoli that have approximately 17 individual alveoli on them. All right, so this takes us all the way down to the end, right? So you can see these tissues. You've got some musculature through there, right? You've got blood vessels through there. And this is where the breathing, the respiration actually happens. All right, so alveoli differ in size based on gravity. I'm standing upright, upright position, and I am breathing spontaneously, okay? So the alveoli in my apex are larger or smaller than in my base? Larger, right? So there's a pressure difference in my body right now. So when you look at somebody who's lying down, for example, the apex changes to now what would be considered your anterior, right? So now that's the apex, that's what's up high, right? That's what's most to the ceiling, okay? Those alveoli now become larger, and the ones at your base, your posterior, now become smaller, all right? So that's important as we continue to move through here. All right, so as lung volumes increase, airway diameter increases as well. So that just makes sense, right? So if you have these small alveoli and your expiration basically deflated, right? So when I create this negative pressure, I pull this air in, of course things are going to get larger, right? It's going to expand to take this volume that we've now brought into our body, and it's going to expand our airways. It's going to expand it and open our alveoli. It's going to expand and open these small airways that we have. All right. So when we look at increase in airway resistance allowed by passive stretching, okay, well that's important. So when you look at airway pressures, why do airway pressures matter? So airway pressures matter because when you really over pressurize somebody, a lot of different things happen in your body. You have risk of rupturing somebody if they have a bleb, or you can rupture an alveolar sac. That's a bad day. You don't really want to do that. Okay? If they've got some kind of disease process that's going on, if they're in the midst of some kind of bronchospasm, an asthma attack, for example, right? Now our airway pressures are going up. So it's really important to understand that airway resistance in our world matters, because position of the patient under anesthesia, whether they have a restrictive process going on because we have them strapped to the bed, what their underlying COPD or pulmonary status is, can interfere with the amount of stretching that we're designed to have, but we may not have access to for this patient because of whatever the disease process is that they have. All right, so smaller volumes below FRC can cause increased airway pressures. It's related to airway closure. So when you think of atelectasis, okay, what happens to the airways? Generally they close, right? So I think it may be the next. We'll get to it in a minute. But airways close depending on how much FiO2 you give people to. There's different kinds of atelectasis, right? So if you have obstruction, you can basically absorb the air that's behind that, or the volume that's behind that. And then those airways can close behind it. So if you have somebody that's really congested, somebody that's having some sort of a spasm where the airways are closing, what's distal to that spasm, distal to that obstruction, can be absorbed, and now it's gone. So what's the filler gas that keeps us open?
Nitrogen. Nitrogen?
Nitrogen, okay? So, how does that work? Nitrogen is not going across the membrane. What's in the atmosphere for nitrogen, roughly?
70?
78, 79%, right? Oxygen, roughly 21% in the atmosphere. Well, nitrogen is what keeps us open. Well, that's important. So we'll talk about that in just a little bit. Okay, so smooth airway muscles have both neural and humoral triggers. So when you look at how this works, why do people have bronchospasm? Why do people collapse their airways? What happens when you have an allergic reaction to something? Okay, it's generally mediated by parasympathetic. Parasympathetic system within your pulmonary tissue is going to cause pulmonary constriction. Okay, constriction. So if you think about constriction in pulmonary, parasympathetic is what you should be thinking. So when you look at acetylcholine, muscarinic receptors within the smooth muscles of the airway causes bronchoconstriction. Okay, acetylcholine, parasympathetic, muscarinic, constriction. All right, those are important things to remember. Okay, so when somebody has an asthma attack, somebody has an obstruction in the airway, somebody's having difficulty breathing, what are some of the inhaled medicines that we can give them? Albuterol, right? Albuterol, racemic epi, right? Why does that work? Right? Why does it work? Well, we have kind of a fight or flight scenario in our body, right? You get excited, you get scared. Okay, I gotta go. Either I'm gonna do this or I'm going that way, right? I gotta go. So one or the other is gonna happen. But what's gonna happen is your sympathetic system really ramps up. Your parasympathetic system really kind of goes into hibernation for a little bit. But when you dump out all this epi and more epi, your body's ready to do something. When your body's ready to do something, it needs a few things. It needs information. What kind of information do you need? Your pupils dilate big, right? You need information. Your brain needs to know what is around me, what's the danger, which way can I go, okay? Next is, I need fuel to be able to get the hell out of here or put up a fight, okay? I don't know if any of you guys watch either, like real wrestling, not WWE jumping off, like real wrestling where it's really hard to hang on to somebody else, or these MMA fighters. You ever watch these guys go out and punch for a few minutes? Especially the big dudes. After a couple minutes, they're like barely throwing an arm because they are exhausted, right? Because that big input of oxygen, they can't get enough. Their muscles need that oxygen. So when you think about how the parasympathetic and sympathetic systems work together, the sympathetic system is going to decrease this constriction. It's actually going to help open the airways. It wants all that oxygen in the body. You need it because you need to do something. You need to go. All right. So pharmacologic blockade of the parasympathetic system. So we can give medications to block it. We can give catecholamines, right? Adrenergically can kind of reverse that constriction and cause dilation. We can actually go in and do, well, we clip the vagus nerve that runs to the pulmonary tissue, right? That is an extraordinary step to take for somebody that has bad airway disease, that is constricted. To take and get rid of the vagus nerve innervation to that, that's an extraordinary step, but it does happen, all right? So beta 2 adrenergic receptors are present in the peripheral lung tissue and cause bronchodilation, right? So that's where the racemic epi, right, any of your catecholamines, anything that we're giving that's stimulating that is going to kind of open up the airways. In anesthesia, what you guys are going to find from time to time is the patient's not going to be quite deep enough, all right? Not that you don't want them to be, but they have a reactive airway, you're trying to wake them up, you are trying to wake them on purpose, and they have a bronchospasm. And it's really severe. You can't move air. What's one of the things that you can do? You can give them low-dose epi, right? Low dose, like mics. 10, 5 mics. Very small amount. That becomes a milligram vial, right? So you're diluting this very concentrated into very dilute epi. That can break a bronchoconstriction or a bronchospasm very quickly. So that's one of the things that you need to have in the back of your mind for a really severe bronchospasm in the OR, is that you have access to epi.
I was listening to a guy that said that he likes to make a bag of baby epi in situations like that, where he'll take that milligram and squirt it into a 100 ml bag, so he can have like that 10 mics per ml.
Right.
And he just kind of squirt it in there.
There's healthcare has cost things that, as a nurse, you were aware of cost, right? We were aware of cost when we were ICU nurses. We definitely were involved with saving costs, not spending this, trying to be responsible for things. In anesthesia, our regimen that we have available to us, either drugs or supplies, is narrow, okay? We don't have access to everything that you had access to on the floor. There's some things that you really want to have access to that you just simply don't have access to. So to do that, sometimes become very difficult depending on, do you even have access to 100 ml bags? I can tell you at Halifax, we don't even have access to them. They're not around. The smallest bag that we have available for us is 250s. 250s, 500s, and meters. Yeah, and 250, because most of the stuff's manufactured in Puerto Rico. Most of IV solutions are manufactured in Puerto Rico, well, they're not really manufactured too much right now. So the supplies are very tight. It's not a bad idea. If you have access to it, you can do it, fantastic, but that's tough.
Yeah.
Depends on where you're at. If you have access to supplies, great, but that's tough. All right, so next step, how can we have other things interfere with our breathing or our ventilation? Well, we can have this non-adrenergic, non-cholinergic receptors, histamine, okay? This is when you get into your, I don't really like dogs, I don't really like cats. Whenever I'm around cheese or peanut butter, I can't breathe. None of those things affect me. So I don't like my wife's cat. Put it outside. It's cold as far as I care, but some of you guys love cats, I know it. All right, so anyway, I'm pretty sure the cat's retarded. So anyway, histamine. There are things that you're going to breathe that your body just goes, I don't like that, right? I don't like that, and it's going to have a reaction to it. My sister-in-law, I don't know if I've ever told you guys this story, my sister-in-law is a severe asthmatic. I've been with my wife for 25 years. In 25 years that we've been together, she's been hospitalized and intubated 7 times, right, because of her asthma. 7 times. She's only a couple of years older than me. So that's severe allergies, right? And it's all from allergies. When she gets exposed to certain things, she cannot react to it. Her body just basically like, nope, I don't want any of that anymore. It just shuts down. Okay, so really important to understand when you get into histamine, and it's a histamine-mediated reaction, there are things that we can give patients to help this, right? We can give epi, that's going to help open us back up. We can give Benadryl, right? What are some other things if somebody comes in anaphylaxis, what else do we give?
Steroids.
H2 blockers, right?
Yeah.
Why? Because they're there. They cause they can cause bronchoconstriction and dilation. So we want to have H2 so we can get the dilation out of that, right? That's why you need to understand when you give a drug, it's for a reason. Somebody comes in anaphylaxis, we generally will give a few things. Well, why do you give those few things? If you want to give them epi, that helps increase our airway, right? It also helps with our blood pressure. It helps with a lot of things when we give epi. Benadryl, we're trying to decrease this histamine response. And we're giving the H2, it helps with bronchodilation, right? All those things help us out. That's a good thing. All right, so looking at physiology. I'm in an upright standing position, yes.
So does activating the H2 receptor cause bronchodilation or bronchoconstriction?
Dilation.
So isn't Zantac an H2?
Two blocker, I apologize.
So it causes bronchoconstriction.
Constriction, so we want to block it.
It causes
Dilation. Correct, yeah. All
So
right.
H1 receptors still cause bronchoconstriction too, though? They both do?
Right, they're both going to have an effect on constriction and dilation. So when we're giving a blocker, this is essentially what this is saying to you is if you give an H2 receptor is going to, depending on what we're doing to it, whether it's being stimulated by histamine and it's creating a constriction, and we're giving a blocker, which is going to help it relax and dilate. That's what's going on with that. Does that help clear it? Okay. All right, so blood flow. Again, I'm in an upright position. If I was supine or prone, whatever's dependent has the greatest blood flow. Kind of gravity. Okay, so I'm upright. My lungs and the bases have the best blood flow. Right now, spontaneously breathing, I also have the best ventilation in the bases. So I'm at a really good place as far as when I take a breath in, I'm doing the most ventilation in the bases, and I have good blood flow through the bases. Okay, that's optimal. We want to have that. That's good. So, and we're going to talk about HPV here in a little bit, but it redistributes blood away from poorly ventilated alveoli. We'll talk about that a little bit more in just a little bit. So, perfusion is greatest at the bases. Perfusion is greatest at the bases. Some it's in a lateral position, right? Greatest at the base. All right. So when we look at the dynamics of breathing, as the diaphragm descends, it causes negative in the apex. The bases are going to have smaller alveoli. That's called zones of West. We're going to talk about that in just a little bit. So when we talk about what happens in the apex, why are we in this sort of scenario where these are at a pressure where they're larger? Okay, so you have less movement just based on your anatomy. Your ribs up here in the top part of your rib cage, they don't move as much, okay? When you think of your rib cage down here, these ribs down here are going to move a lot more. They have a lot more movement with the tail handle effect. As your space increases, as this chest wall gets bigger, as your ribs move, the lung wants to stick to the chest wall. That's what's creating that pull and the negative pressure that's pulling things down. But what your ribs want to do, what your chest wall wants to do, is to relax and go back into this sort of neutral position as if you're exhaled, right? So you have to work to open it up. Passive kind of closes back down. Okay? Work opens up, passive it goes back down. All right, so the lung follows the chest wall. Right? You know that there's some fluid there, some pleural fluid between the lung and the chest wall. Sometimes these get adhered. Sometimes your lungs can even be adhered to your chest wall. So during your training, you guys will do some cases where you're doing a pleurodesis and doing different things where you're going and you're actually pulling the lung off of the chest wall because it's actually adhered to the chest wall. Right? These are interesting cases. So when you think tail handle effect, it does this. So when I'm in a relaxed position, exhale, my ribs are kind of down in this position. When I take a breath in, my ribs want to move up this way. That's increasing my circumference here. That's increasing the size of the chest cavity. That is making negative pressure inside because I'm expanding that. That's what's pulling volume into the lung. Right, that's called tail handle effect. The mnemonic to remember, intercostal muscles. Internal intercostal muscles are for expiration, aid in expiration. External intercostals for inspiration. So the mnemonic is in, ex, in. Internal for expiration, external for inspiration. Again, just intercostal muscle. This will become important later when you look at this vein, artery, nerve, when you're doing intercostal blocks, right? When you look at, in the future, we'll talk about pulmonary procedures where you're going in, you're doing VATS or some kind of case that you're messing with the lung. Either you're going in there to take a wedge out, to take a lung out, do a biopsy, whatever. It's really important to understand this anatomy here because when you do an intercostal block, you have to hit the rib and then walk off the bottom, and then you inject your local. Okay, that's the landmarks for doing an intercostal block. You put your needle in, you hit the rib on purpose, you direct down, you just walk right off the end of that rib and you inject your local, because your nerve is right underneath. What's also really important to remember is where the artery is. Because you're gonna have some surgeons are a little rougher than other surgeons, and they're gonna start jamming trocars in there, or they're gonna make an incision through there, and they're gonna get into that artery. Now, this isn't a huge artery. This isn't the aorta or a femoral. It's small. But guess what it does do? It bleeds. It bleeds. It bleeds. And it bleeds. There's been some cases, and I'm sure some of the upperclassmen will tell you, because I've seen it personally myself, where the case is going along, and you look on the floor, and there's a puddle of blood. It's a lung case. You shouldn't have blood right now. Why are they bleeding? Well, the surgeon's gotten into this intercostal artery, the artery that runs right under the rib with his trocar, and it's just slowly bleeding out. It's going under the drape, it's landing on the bed, and it's dripping on the floor. No one's looking at it, no one's seeing it, it's just this nice steady trickle of blood that just keeps coming. Okay, so it's really important when you're in some of these cases to every once in a while look under the drape and look at the floor. Make sure there's not a lot of blood laying down there, because people bleed. All right, this kind of gives you an idea on this pale handle effect. This is expiration, kind of a relaxed position. Inspiration, thoracic cage moves up, and you get that big opening into your thoracic cage. Your diaphragm contracts, and you've got this negative pressure, and you're filling up with volume. All right, so the lungs want to recoil, the thoracic cage wants to expand. So as you're pulling up your rib cage, when you're doing the work of breathing, your lungs, they're going with your chest wall, right? But they really want to come back to kind of a relaxed position, all right? So that's pressure in there that you need to understand. So the pleural cavity has a vacuum. That's how that negative pressure is happening, all right? So as you're raising up, you've got this pull of your lungs. Your lungs they're not rigid, right? So they're very compliant in there, and they're going to move, but they really want to get back to a relaxed position. All right, so VQ, you guys have all heard of VQ, VQ mismatch. What does all that mean? We'll talk about that in just a little bit. So when you talk about VQ, you need to understand that there are differences in pressures with ventilation and perfusion. There's differences, and we'll talk about that in just a second. I don't want to get ahead of myself. I know it's in the presentation, so I'm wanting to get to it. All right, so at the end of expiration, you're at -5 centimeters of water pressure in your inner thoracic cavity. So during inspiration, it goes to a -7.5, all right? This is rough numbers, all right? So there's a difference here of about 5 centimeters of water. So that's how you get this. You have negative pressure in here. As you do this pale handle effect, your ribs move up, your diameter increases, you increase the negativity. All right, you become more negative. Okay, you become more negative. That's why you're drawing the air in. Go. Yep.
Whenever I was reading, I was a little confused because why would they measure it in centimeters of water instead of millimeters of mercury if atmospheric pressure is measured in millimeters of mercury, and that's what's causing it?
So you will find that things can be measured either measurement, I guess, I don't know, whatever, Celsius centigrade or Celsius Fahrenheit, right? So it's giving you the same information. Why it's measured in water and not millimeters of mercury, I don't know. Yeah.
Overcoming atmospheric pressure.
Yeah. Why it's measured that way. I don't know. I mean, I guess it could be, but yeah, when you look at vapor pressure, atmospheric pressure, yes, they are millimeters of mercury. Why would it be water? question. Okay, back to it. Okay, so this is basically, these are terms that, with definitions, is really all that is. I'm not going to read them off to you. It talks about driving pressure, trans-airway pressure. So that's the pressure difference between the mouth, what's in the mouth and what's in the trachea. Transpulmonary pressure, pressure between the alveoli, pressure and the pleural pressure. So you may come across these at some point in the future. It's not something that I'm going to test you on these specifically, but this may be terminology that you come across at some point in the future here. This is a description kind of on a diagram of what your transpulmonary pressure is. When you think of transpulmonary pressure, the pressure between the alveolar pressure and the pleural pressure. So alveolar pressure, pleural pressure. So as your pleural space becomes more negative, your alveolar pressure is going to increase. That's the difference. All right, the difference is called your transpulmonary pressure. So that's not going to be something that I'm going to be asking you about. Okay, so VQ. I knew this was coming. All right, so normal VQ is 0.08. Oh, 0.8 decibels. All right, 0.8. That's normal. So why isn't it 1? Because 1 would be perfect, right? 1's 100%, so it's basically 80%.
You're always going to have more perfusion than, or is it vice versa?
Right. Okay. Do you guys hear that? So you have a 4-liter and 5-liter thing. Okay. We've heard of that before. 4 liters of what? Ventilation. 5 liters of what?
Cardiac output.
Right.
Yeah.
So that's where you want to be. This is normal. This is where you want to be. Okay, so you're always going to have, or at least you should, what we want is that more perfusion going through the lung tissue than ventilation. All right, that's a good thing. That's normal. When this becomes smaller, when that percentage or that number becomes smaller, there's a reason why. All right, it could be shunt, it could be hypoventilation, it could be different disease states. We'll talk about those. So we're going to start talking about zones of West. Any of you guys heard zones of West before? Okay, so good. So big A, little B. All right? You've probably seen this before. You've talked about zones of West. So zone 1, 2, 3. We'll talk about them here. All right, so zone 1. Zone 1's generally wherever the apex is. So is this alveolar?
Should be.
Yeah. Alveolar is greater than
Arterial.
Greater
than venous.
Okay. So alveolar pressure is greater than arterial. Alveolar pressure. This is an indication of what our alveoli is. If the alveolar pressure is greater, this is going to mean that that alveoli has a lot of pressure in it already. It's already full, or at least has some capacity in there, or some volume in there that's increasing its capacity. All right. Zone 2, so arterial is greater than alveolar, which is greater than venous. Right. So this is going to be a moderately sized, smaller than zone 1. Zone 2, we've got greater arterial flow than alveolar pressure, venous pressure. Okay. And then zone 3, alveolar pressure is the lowest. Okay, alveolar pressure is the lowest. So you have the smallest alveolar or alveoli in zone 3. Now, when you're in an upright position, zone 3 is mainly in the bases, but zone 3 can be anywhere in the lung tissue. All right, all of these zones can be anywhere in the tissue. All right, so you need to understand that concept of zone 1 is not only in the apex. Zone 2 is not only in the middle, and zone 3 is not only at the bases. These are mixed in all together. The majority of zone 1 is in the apex. The majority of zone 3 is in the bases. So this kind of just gives you another hand grenade look at these different pressures. So in zone 1, alveolar pressure exceeds arterial, which exceeds venous. So if you think about what's happening with ventilation and perfusion, how much volume, how much oxygen is actually getting into the blood supply in zone 1? A lot? A little bit? Moderate? Not a lot. Right? Not very much. Why? Because the pressure is so great in here, you're actually occluding your flow. Okay, you're actually occluding your flow through because the pressure is so high. So when you get into zone 2, it starts to normalize a little bit. Now you've got flow that's coming through. Yes, you have some higher pressure in the alveoli, but you actually have the ability to do some across the membrane ventilation here, right? You can get some oxygen in, you can get some CO2 out. In this zone 1, very difficult. It's occluded. Zone 2, a little bit better. Not great, not perfect, but better. Zone 3, now you're really moving volume. You're moving gases in and out. Oxygen's coming in, CO2's coming out. You have good flow across the membrane. That's ideal, right? That's ideal. So when you're in an upright position in zone 3, where you have the best ventilation and the best perfusion, you're oxygenating that patient really well. The ventilation is really good in that zone. Gives you an idea on kind of the amount of change. So if I'm taking in a big deep breath or just a normal breath, so if this is my starting point with my zone 1, it's already a big dilated alveoli. Am I going to take in more volume? Yeah, I'm going to take in some volume there, but I'm going to take a lot of volume down in 3. Okay? So the change, the amount of change is really dramatic between an alveoli that's in expiration in zone 3 to inhalation in zone 3. So mechanical ventilation screws it all up, right? So this is where we get to come in and throw a wrench into it, okay? There are going to be circumstances, and I had one this week with a patient, really bad lung history. I did not want to put her on the ventilator. Because if I put her on the ventilator, the risk is I could not get her extubated, right? When you have somebody that's really fragile COPD, really bad pulmonary history, they're on all kinds of things for their breathing, right? They're on every inhaler, they wear oxygen at home, they're taking all kinds of stuff, and yet still smoking cigarettes every day, right? Love that. You need to stay away from their airway. You need to keep them breathing. So if you can put a needle to it and block a nerve, you should probably do that. A regional anesthetic is best for that patient. So this patient was having something done with her leg. It wasn't a knee replacement, but something done with her leg. And I chose to do a spinal for her. Now I had to educate her because her big thing was, spinal, that's a needle, I don't want a needle in my back. You need to educate your patients as to why exactly this technique is better than another technique. So if I can put a breathing tube in you, no problem. You got no teeth, you're about 91 pounds, she was 40 kilos, and they're 41 kilos. And so you're talking teeny tiny, just look like she's wasting away, right? So putting a tube in is not going to be the problem. Getting the tube out, that's the problem. So that's part of the things that you guys need to consider when you're looking at what kind of anesthetic you want to do. Because when you go into mechanical ventilation, you may have really good blood flow in the bases, but your ventilation is not going to the bases anymore. You're sending that all path of least resistance. All right, we'll talk about that in just a little bit here. Yes.
What's the physiologic reasoning behind it out?
So their lung capacities are so bad that when you give them a break, when you let them rest, and you take their work of breathing away from them, their body goes, thank God. Yep, I'm not interested in breathing. Right? It happens with older people too, where you put a tube in them, you just can't get them extubated. People with real bad lung disease, you need to keep them breathing. Put them on an LMA, put a spinal in them, do something that keeps them breathing, make them work.
Never mind, that was my question.
Okay.
Like, did you do LMA?
No, spinal for her.
Well, I mean, but was she awake or did you like?
No. So when you do a spinal, generally you put them on a propofol infusion, right? So not enough where you need to put an oral airway in or nasal trumpet or do just enough to keep them asleep. That's it. No, more than that. 25 mics.
I mean, 25.
So she's 40 kilos, you said?
Yeah, 40 kilos.
So
So-
40 mics a
So
minute?
remember, people who have a history like this generally don't only smoke. Generally, they tip other things also.
Oh,
So their
they're induced.
ability to take a lot of anesthesia drugs is really high.
The upper.
Right, so this lady, 41 kilos, I had her running at 125 mics per minute. 125 mics. Now, I've come into a room where I had one of the classmates that's ahead of you guys fighting here, and we have spinal in the patient. The patient was very numb, comfortable. It was the same sort of thing. Bad lung history, we needed a spinal, we did not need to mess with their airway. It was the best choice for the anesthesia. So I leave the room, I come back, and the pump, I've never seen a pump set to 250 mics per kilo per minute. 250 mics per kilo per minute. This was like a 90 kilo patient. So like you're going through 20 cc's in like 10 minutes. Right? Like it is blowing through propofol. And the blood pressure was 130.
Oh.
Right? Like they needed that. They even had a spinal, right? So think about it. They had a spinal, they're dilated, they're still on all of this propofol, and they still have a pressure of 130. Like, ridiculous. I remember looking at the pump, and I just looked at him, I couldn't say anything, because I was like, what is happening here? I've never had a pump that high, and you ramped it up when I wasn't in the room to that high. When I left, it was 100. I came back, it was 250, right? So it was a bit shocking for me, but the patient was railroad tracks. Vital signs were absolutely railroad tracks. 130 over 70, 130 over 70, 130 over 70. So it's one of those things.
Is that when you would wonder though if maybe your spinal's wearing off and stuff?
No. No, they weren't reacting to the spinal or to the stimulation of surgery. They just kept talking. They were just awake. They were awake. Like with 100 mics per kilo per minute. They were awake and talking. Right? So she just kept going, click, yeah, still talking, click, right? Hold on, I really don't want to hear you anymore. Right? And it's like it just kept going up. It just kept going up, it just kept going up, and finally the patient was asleep. They weren't reacting, they weren't going, ow, ooh, no, they're just like, oh, so, you know, talking about their dog and their work week and just whatever. Some people, when you think of MAC, right, when you think of MAC with your vapor, MAC is 50%. There's a bell-shaped curve, right? So there's somebody that's all the way over here, and there's somebody else that's all the way over here. MAC is right in the middle, right, 50%. Somebody's over here. Just happened to be that this patient, 250 mics per kilo per minute, I didn't know the pump could go that high. Oh, that's incredible. But they needed it. All right, so get back to this. So when we talk about, is there any other questions on that? Okay, so a mechanical ventilation. So let's go back to this. Mechanical ventilation. Blood flow is not going to change. Blood flow is still going to go to the bases. Okay? Blood flow is still going to the bases. But your volume, now your ventilation, whatever you're pushing into the patient, rather than pulling into the patient, but you're pushing into the patient is going past of least resistance. It's going to the apexes. It wants to go to where the alveoli are already open. This is nice and easy for me. I don't have to do any work. I don't have to push anything. I'm just going right to these big open spaces. So when you look at VQ, the more we do to the patient, the worse their VQ mismatch is. Okay? There's a. All right, it's down the road a little bit here. A couple of slides. I thought it was next, but it's not. All right, we'll get back to that. So with your VQ, as we intervene more with the patient, we are creating more of a VQ mismatch. All right, so passive least resistance is basically what we're talking about. So HPV. So let's talk about that real quick. So HPV, hypoxic pulmonary vasoconstriction. Who can tell me what that is?
It's when there's an area of less perfusion and the blood is being redirected in an area of more perfusion to maintain oxygenation.
So, you're close.
It's an area for ventilation.
Okay.
And so the lungs or the body constricts the vessels so that more circulation can go to other areas.
Goes to
So
better
lungs-
ventilated areas.
Okay.
Right. So, if you have an area in your lung that is occluded for some kind, right? Some kind of blockage, atelectasis, it doesn't matter. Something's not ventilating well in this localized area. It's probably not going to be the entire lung. It's probably not going to be an entire lobe, okay? But a small area in the lung that has some atelectasis, some collapse, some obstruction. Well, if the blood flow is going there and it's not picking up oxygen, why does it need to go there? It doesn't. So what happens? It redirects to someplace else. The body basically goes, well, that's useless. Shut off blood flow there. So now it's rerouted. Okay, so now it's going to the area where you are moving oxygen and carbon dioxide across. Okay, so HPV is where you have some sort of localized, you're not ventilating well. And your body says, I don't like to send this good blood to that area because I'm not getting any return on my investment. So I'm going to block this, and I'm going to reroute it to a place where I'm going to get this good oxygen that I want. All right, so when we talk about HPV, before I get off of this, volatile anesthetics block that. So let's think about that for a second. So volatile anesthetics above 1 MAC block HPV, what's the risk?
So your blood is equally distributed.
Increased ventilation perfusion mismatch. Do you guys agree with that? 100% yes. Yes. Because if I'm going to send the ventilation to an area that's not being perfused, well, that's not really doing me a whole lot of good, is it? Okay? When you have volatile anesthetic on above 1 MAC, 50%, MAC is 50%. You're going to take everyone to 1 MAC, right? MAC for each patient is a little different. For me, it may be, I'm lightweight. I don't need much, right? I'm not going to say you. You might need more. That's all I'm going to say. I don't know. For sure. Somebody else may need more, okay? Someone else may need more. So if I'm at 0.8 isoflurane or 1.8 sevoflurane for me, someone else may need 2.3, right? Or 1.2 on the ISO, okay? So that's possible, right? So there's 50% mark, 50% of the population is going to be right there. 2.1 on your SIVO, 1.1 on your ISO, great, life is good, no problem. I'm not having to chase their pressure, but they're not reacting either. This is a good day. Some need more, some need less. The point is, when you get to that, when you get to above 1 MAC, HPV is now blunted. So your perfusion, your VQ is now being even more disrupted. And we'll talk about VQ a little more here because there's a chart here that'll start to put it together for you. So if gas flow is to the apex, blood flows to the bases, then clearly that's going to create the mismatch. All right, so atelectasis. You guys have heard of atelectasis. You know what atelectasis is. Understand this one point. Anything you do to a patient increases atelectasis. When you guys do anesthesia on a patient, if you put 100% FiO2 to pre-oxygenate, what are you really doing? You're denitrogenating the patient.
Collapsing.
Pre-oxygenation is, okay, pre-oxygenation, that's the term we like to hear. But you're really denitrogenating the patient. You're really taking all that nitrogen out. So what happens when your filler gas is gone? What happens to your alveoli? They close, right? They close. So if you are inducing someone for general anesthesia, and you turn on your 6 to 8 liters, and you stick that mask on their face, and you do 2, 3, 4, 5 minutes because you're waiting on your anesthesiologist to get there, right? You fully pre-oxygenated that patient. Every minute that goes by, more atelectasis, more atelectasis, more atelectasis, more atelectasis. You need to understand that that's what you're doing to the patient. So there are many patients out there that can't afford more atelectasis, right? That makes sense. When you think of people that are really obese, that hypoventilate already, because they just can't breathe, or an elderly person that doesn't do a lot of coughing, deep breathing, they're not out moving around, taking big deep breaths, and you increase their atelectasis, their post-operative complication rate goes really high. The United States is one of the only countries left that encourages 100% FiO2 on induction and emergence. All of Europe, so when you guys have the opportunity to travel, I would recommend that you do go to Europe. They don't put people to sleep, nor wake them up on 100% FiO2. Don't do it. Because it's better for patients to have the nitrogen placeholder so they don't have as much atelectasis. And if you don't do something, and if you don't do something to open the airways back up, you've done this great job bringing the patient in the room, getting them onto the bed, putting them onto the monitors, putting this oxygen mask on them, take deep breaths, sir, take deep breaths, sir, take deep breaths, sir. IV induction, put the tube in, nailed it, done. All right, case is over. You've done no recruiting breaths that whole case. The atelectasis is just continuing to increase. You have to do recruiting breaths during the case. Ventilators in the ICU have sigh breaths built in every 5 minutes or every so many breaths. It's built into the mechanics of the ventilators in the ICU. That does not happen with our anesthesia ventilators. So if you want to give recruiting breaths, you have to do it manually. Take them off the ventilator, close your EPL valve, squeeze the bag, hold it, hold it, hold it, hold it, hold it, release it, open your APL, let them exhale, close your APL, squeeze the bag, take it to about 40, hold it, 10 seconds, open your APL, release, squeeze the bag. What was your question?
So the trade-off with not denitrogenating though is that, like, I feel like my window to get the tube in might be a lot shorter.
So that is true.
Okay.
So part of the rationale that we use in the US is that, well, if you pre-oxygenate the patient, you have more time. Is that true? Yes, that's true. You have more oxygen available in the alveoli. But how long does it take before you've created so much atelectasis that your reserve is low already, right? So to run someone on 100% FiO2, now how many of you guys are at Memorial? The main, have you guys been in the main OR yet? How much air do you have available to you?
None.
You're running a whole case on 100%. The whole case on 100%, right? That's not good for patients. If you're not doing recruiting breaths during that, the amount of atelectasis that patient is waking up with is astronomical. You have to open them up. You have to open up their airways.
So I had no idea why I was doing this, but now it kind of makes sense. So when I went to extubate my patient yesterday, they had me do what you said, but during extubation, just hold pressure. Is that doing the same thing? Does it work?
Part of that whole close your APL valve and hold pressure when you pull the tube is for secretions. It's not going to do a lot in the way of creating a better environment for reducing atelectasis. That's not really what that's for. The truth behind it there.
Oh, yeah, I read in Miller that says that if you use recruiting breathing, and then after that alveoli only holds about 10 minutes.
That's
if
right.
you continue to use 100% oxygen, you're closed up again. So
Yep.
it's encouraged to use
Not
low-
even 100%,
low-
even
high.
less than 100%, right? So if you're above 30%, you're still going to start to you're going to start to have atelectasis build back up. When you do recruiting maneuver, you're supposed to do that every 15 to 20 minutes because that's about the amount of time it's going to take for the alveoli to recollapse. And that's on 60% FiO2. So if you're running like at Memorial 100% for the whole case, you have to open them back up. We did a study here, the class that graduated in 2015. We did a study, I was the chair and then the two students, where we did at Halifax, LMA cases. Okay, so the patient spontaneously breathing. Our control was that the patients who got 100% on induction, 60% during the case, which is pretty standard, they each go to a liter flow each, so it's roughly 60% FiO2, and then back to 100% on emergence. versus patients who had 100% on induction, 60% on maintenance, and 60% wake up. We just left them on that maintenance 60%, woke them up, took them to PACU without nasal cannulas. Okay? What was their oxygen saturation, and who needed intervention as far as additional oxygen once they got to PACU? The patients who woke up on 100% were twice as likely to need a nasal cannula in PACU than patients who did not receive 100% oxygen. Twice as likely in our study. Very limited, small study, a couple hundred patients, but in the course of 2 months, twice as likely if you woke them up on 100% that they would need supplemental oxygen in PACU. When you guys work with me, I do not wake patients up on 100%. If you put 100% on a patient that I'm waking up with you, I'm gonna come behind you and change it. Now, there's gonna be other people that you work with that will slap your hand and read you the riot act for not waking someone up at 100%. So you're gonna do what you have to do in the room that you're in. But just remember, when you're in a room with me, if I see 100% on there, I'm gonna ask you why. And we'll have this discussion. There was a couple of hands. Do you have a question? No?
I think Amy did.
Okay. Go for it.
So I worked with a CRNA who ran 100% of her case, and I asked her if she was concerned, what her thought process was. And she said, she pulled up a whole study and made me read it about absorption and atelectasis, and at the end of it, it basically said that the results were not enough to say that it was a real thing.
Interesting.
Yeah.
How old was this study? Can you send it to me? Do you have it?
I don't, but I can find it.
If you can find it, I'd like to read it.
Okay.
Sure.
Because
See what
all the
the
data
left
out of
one is.
Europe says otherwise.
And granted, I was just reading what she handed me on her phone and
Right.
said, hey, here, read this, so I wasn't really gut picking through it, I was just kind of looking at it.
I'd be curious to read that.
What's
up with that?
I did not do
Level of evidence.
Not putting the patient on 100% O2, would that be the same if you are using nitrous oxide?
All right, so let's talk about that. That's a very good question. So if you put someone on a mixture, let's say 50-50, oxygen and nitrogen.
It's so diffusible,
A
dude.
liter each, 2 liters each, whatever. So they're on basically 50% nitrous, 50% oxygen. What do you think the amount of atelectasis is that you're creating that environment?
Where you're introducing nitrous oxide. You're
Huge.
introducing nitrogen.
It's super diffusible.
Nitrous oxide gets turned off and then you're gonna
So I disagree with that. All right. How does second gas effect work? What's second gas effect?
So you increase,
It's
by
in-
adding a second gas,
Which would be what?
nitrous,
Okay.
you increase the concentration of the other gas
Why?
because the nitrogen it diffuses more quickly, and
Nitrous.
so your nitrous diffuses more quickly, and so your alveoli collapse, and then the concentration of whatever gas remains
Right.
in the alveoli is more.
That's correct. That's correct. So is oxygen diffusible?
Mhm.
Yes.
Okay. So if I add nitrous and oxygen, the only 2 molecules I have in the alveoli is nitrous and oxygen. What happens to the nitrous? It immediately goes into the blood. Immediately
It's
goes
like
into the blood. What
86,000
happens to the
times more
oxygen?
diffusible.
It follows it. It
Yeah.
goes right into the blood. Right? So now you're left with an alveoli that does, well, I don't need it. I'm closed. I'm empty because I don't have anything left. Everything's gone into the blood already. Okay? What you'll see me do, and I'm the only person that I've ever seen do it, I leave air on when I run nitrous. So I'll run 2 liters of nitrous, a liter of air, and a liter of oxygen, which puts you at about 30% FiO2 when you run it that way. 2 liters of nitrous, 1 of air, 1 of oxygen is roughly 30% FiO2.
Interesting.
Because I know at that point, I've got some nitrogen that I'm leaving in that alveoli. I'm decreasing my chance of atelectasis. What I'm not thinking about is what's good for me right now. What I'm thinking about is what's good for this patient after I drop them off. Because after I drop them off, a lot of things happen to patients after you drop them off. Right? All right. That was a lot. That was way further than I thought we were. All right. So, general anesthetics blocked. All right. We talked about that for death, I think. All right. Paralysis increases resistance to gas flow. Absorption atelectasis frequently seen to varying degrees. Okay. So here's the chart I was looking for. So, spontaneous ventilation. 0.8 normal. 4/5, right? 4/5. Well, now I'm going to have a spontaneously ventilated patient who's now anesthetized. Patient on LMA, right? Patient on LMA. Put an LMA in the patient, if they're asleep, I got them on anesthesia gases, or I have propofol running on. What happens to their VQ? It decreases, so now we're at 0.7. Okay, spontaneously breathing, simply just anesthetized. We've given them some anesthesia, they're asleep. Now, positive pressure. Now we have switched them onto the ventilator. Now they have a breathing tube in. Positive pressure, ventilation, anesthetized. Okay? So, this is a patient who has a breathing tube in, who now we're giving pressure support to. All right, now PSP Pro, it's the end of the case, breathing on their own. But we're giving them positive pressure ventilation. We're helping push that air in. What happens to the VQ? 0.5. That's a dramatic decrease, right? Because we're simply giving them positive pressure. So instead of them initiating the breath, pulling the air in, we're shoving it into them, okay? When we're shoving it into them, path of least resistance. It's going to zone 1. It's going to zone 2. Zone 3 is last. Zone 3 is where you have your best ventilation and perfusion, right? But it's going there last. So our VQ is getting worse. Now we have positive pressure ventilation on an anesthetized and paralyzed patient. Half of normal. Here's normal. Positive pressure, anesthetized, paralyzed. Half of what's normal. Okay? Now we got them on a MAC of anesthesia, HPV is blunted, we're shoving air into them. Our VQ is half of what it normally is. So what do we do to fix it? We'll increase our FiO2 because that number makes me feel good. I like 100, right? I like the little yellow line to be 100. I don't want the yellow line to be 95. I want it to be 100. When you do things to make you feel good, that's wrong, right? Period. If you're treating a number to make yourself feel better, that's wrong. If a patient comes in and their baseline is 91, and they're at 91 on 60%, or they're on 90 at 60%, leave them alone. They're fine. They don't need a higher FiO2. They don't need to be 100. They don't need to be 100. Okay? You have to look at the patient and understand, what is this patient doing? What's their baseline? Where are they at? What can I do for them? So when I drop them off, they have the best chance of success. Okay, so understand, positive pressure ventilation on an anesthetized paralyzed patient, 0.4. That's half of normal. That's the worst circumstances. How many times do we do this to patients? Every time we put a freaking tube into somebody, right? Every time we put a tube into somebody, we do this to them. So, we cause atelectasis. We cause VQ mismatching. We intervene and create problems. So know how to fix it. You guys are learning how to fix it now. All right. Open chest dynamics. So this is basically talking about different types of pneumothorax. We'll go through these pretty quick. These aren't quite as important for this lecture, but it's something that you guys just need to know about. So, simple pneumothorax, basically there's no communication between the inner thoracic space and the outside lung. Okay, you have a collapsed lung, happens spontaneously in young men often, happens in patients who have ruptured blood. It happens. Sometimes it happens spontaneously, sometimes it happens because we know that there's a purpose. Okay, there's been some kind of traumatic event, somebody comes in with a pneumo, we know about it. All right, so communicating, basically you have a sucking. Got penetrating trauma, some kind of stab wound, bullet wound, shrapnel, a pole through them, a car crash, doesn't matter. Sometimes you will see this, okay? So we're not full of blood, we're not full of fluid, we just have a communication between the outside pressure and the inside, and now the lung is moving asymmetrically in there. It's not moving the way that you would expect it to. All right, so on your communicating, so outside world, right? So when we're looking at how we're moving air in, what happens when the patient is taking a breath in? What are we doing? We're increasing our negative, right? Increasing our negative. So if we're increasing our negative, we're pulling air in through the chest wall. Okay? So what happens to the lung on that side? It raises, all right? Becomes smaller. Because we're pulling air in, we're going to fill this space. We're going to fill this space from the atmosphere through the chest wall. All right? Exhalation, the lung's going to actually fill up and get a little bigger. All right? Expiration. Okay, so tension pneumo, you guys all know what a tension pneumo is. It's not a good day when you have one of those. There may be an opportunity at some point for you guys to do a little needle decompression. Think about, know those structures and what you're going to do that. Right? Which rib?
Second,
The second rib.
second intercostal space.
Yep. Second space, right? Mid-clavicular line. 14 gauge IV. Put in there. It's impressive to hear. All right? It's not a good day when you have that. All right. Hemothorax, basically filling the chest wall with blood. It's not a good day, right? You're squeezing out that lung, you're just filling it, and you're replacing it with something else. All right, so so these are our different tubes. So you guys have all seen, at this point, a double lumen tube. You may or may not have seen a double lumen tube, and you may or may not have seen a bronchial blocker. So we'll talk about those just real quick. So why do we need control over that? Sometimes it's for surgery, sometimes it's for infection. We don't want to put somebody that's lateral, so we're working on the non-dependent lung, right? If you want it to the ceiling, non-dependent lung, maybe it's got some kind of infection in there, and we don't want that to drain over to the dependent lung, so we're going to block it off. We're going to protect the lung. Maybe we need a quiet surgical field for the surgeon, because they're all cardiothoracic surgeons you guys will find are, they can't work unless they need a quiet surgical field, right? They don't want to chase the lung, gets in their way, they get really irritated, and they yell at you. And you turn around and you look at me, and I go, hey, let's fix it. It's not a big deal, but they don't like it. I don't like getting yelled at, you guys don't like getting yelled at, so depends on what's going on. So specialty procedures, again, there's different reasons that you're going to do it. All right, so single lumen tube, standard, right? These are what you guys see and use every day. Don't put it in the right main stem if you can help it. Put it where it's supposed to go. Ventilate both ones at the same time. Not difficult to put in. So there's two versions of the tube. Okay, that's fine. Disadvantages, inability to pull material from operative lung. Yes, if you're trying to isolate a lung and you use a single lumen tube, very difficult to do that unless you put it into the right main stem intentionally. That is done from time to time. Instead of using either a double lumen tube or a blocker, they just intubate into the right lung. Okay. Generally, that would be for surgery on the left lung, right? It wouldn't make sense that if you're trying to do surgery on the right lung that you're going to put a right main stem to, that you're going to intubate the right main stem. Okay, so when you look at bronchial blockers, it looks very similar to a single lumen tube, but it has this extra piece here. Okay, this extra piece runs the length of the tube. It can be retracted or advanced, and it can be directed. All right, so when you intubate the patient with a regular EL, you put the tube into place, you put your bronchoscope down to the end, you're looking at the carina, now you take this blocker and you move it forward, you get it into the right or left main stem, you inflate the balloon, now you've secured or blocked whichever lobe you're trying, or whichever lung you're trying to block. Okay, that makes sense. But you're not going to see these a ton. All right, you're not going to see them a ton. But what you will see are double lumen tubes. So, well, this just talks about the when you're looking at it through your fiber optic bronchoscope. So clearly you're looking for your carina. You're gonna take and look, you're gonna watch what you're doing here. You're gonna run your blocker through, you're gonna run it, let's see, there's D. Run it to the left, you inflate it, you take a look, yes, that's great, everything's fine. All right, like I said, you're not gonna see that often. What you will see are these double lumen tubes. All right, double lumen tubes come two different ways, a right and a left tube. Generally speaking, you will not see very many or have the opportunity to use a right double lumen tube. Generally, you will use a left double lumen tube. Okay? So, have you guys seen these? Anyone seen one of these yet? They're about that big. They are gigantic. All right? They are really big tubes. So, when you're taking a regular single lumen tube, that seems big, but there's plenty of room in there. When you take a double lumen tube, that's less room in there, okay? So when you go to put these in, you have to be really careful that you don't damage vocal cords, that you don't really hurt the patient. It's very easy because this piece, you see how that has a bend on it? That's rigid, okay? That's rigid. So you're putting that DL, you're looking at cords, you're taking this gigantic tube which feels like a stainless steel stylet. It is not pliable whatsoever, and you're putting that through the cords. You advance it past the cords, you take your stylet out, you turn your tube from 12 o'clock to 9 o'clock, and then you advance the tube. The reason you take it from 12 o'clock to 9 o'clock is the handle, there's actually kind of a curve to the tube. So this is that piece here. Here, this handle, you see how it kind of rotates up? The tip of the tube. All right, so this is kind of what you're going to be looking at as you go down your, going down, this is your carina here. Okay, so you've got your bronchoscope, you're looking out the end of the tube here. So your bronchoscope's right here at the end of the tube. This is what you're looking at, carina. There's your endotracheal side of the tube. That's the balloon. Now you're looking into the right. Now you're never going to see this. It's never going to be this pretty. But there's your upper lobe takeoff, and then your middle and your lower lobe takeoff. All right. But you will see the carina clearly. You will see this tube clearly with the cuff, and you will see this takeoff of the right side. All right, so that's basically the sequencing of that. We talked about this already. Basically, how is VQ altered general anesthesia, different positioning, whether or not you have your perfusion is mainly that you're dependent on, right? So your VQ mismatch is greater just based on the position that you're in. We already talked about kind of beat to death effect, general anesthesia. But if you have an open chest, obviously your dynamics change just based on how you do it. Right? All right, shunt. Who can explain shunt? Anybody? Come on, who's got it? Somebody's got it.
I'll try.
Give me a shot.
Unoxygenated blood from the right side, it goes to the left and returns to unoxygenated to the right again.
Okay, so we're bypassing or shunting away from areas that can oxygenate the blood. All right, would you guys agree with that? Yeah?
That's
Okay.
one version of it, I think.
All right, what's the short version?
But no, that's one way it can happen, like a septal defect.
Okay,
That's one way it can happen, and the other way, say you have collapsed alveoli with blood just passing by,
Right.
not exchanging gas. That's another
Right.
way.
so essentially HPV hasn't kicked into that area yet where exactly what he said, you have oxygen, or you have deoxygenated blood running past the alveoli, but it's not picking up oxygen, right? All right. So what's basically the goals of ventilation? You want to maintain your entitled CO2 to a kind of a normal level. When you're talking about two-lung ventilation, now this is kind of referencing one-lung ventilation where you have a lung that's You're in a procedure that needs you to have a double lumen tube and you're isolating the lung. So what do you want to see on your monitor? You want to see what you would see if you have 2 lung ventilation. It should look about the same. Just because you're ventilating one lung and they're operating on the other lung doesn't mean that your entitled CO2 should be 50. All right, it means you're hypoventilating the patient. So let's say we start a procedure, we put a double lumen tube in, we're ventilating both lungs. We have them on a tidal volume of, let's say, 500, okay? We turn them on their side. We occlude the bronchial side of the cuff, so we're ventilating only the right lung, okay? Because the bronchial has to be on the left if it's a left tube, okay? So we're only ventilating the right lung. What would you move your tidal volume to? Would you do anything to it? Would you leave it alone? Would you cut it in half? Or cut it in half? Right, so we're only ventilating one lung. We were 2, right? So it's an 80, 90 kilo patient. We set them on a rate of 10 or 12, 500 tidal volume, go between 5 and 6 liters a minute ventilation. Our intitle's normal, 35 to 40. Regular MAC of gas. Now we're going to take one lung away. We're going to clamp the bronchial side. We're only going to ventilate the right side. What are we doing to the tidal volume on our set tidal volume ventilator?
I say make it,
cut it in half.
I say make it easier on yourself and just switch to pressure control.
Right.
Switch to pressure control.
Right.
That's an
Because
option.
it's true.
If you have them on volume control, if you have a set volume, you don't do anything.
I'd say which lung are we including? We're taking them
It doesn't
down.
matter.
Okay.
It doesn't matter. You don't do anything. Right? Think about what capacity your lungs have. If you try and give me 500 mLs of tidal volume in it, I have a 2-liter bottle on this side and a 2-liter bottle on this side. Right? So I have at least in my mind 4 liters of capacity here. It's more than that, but generally speaking, we'll just call it a 2-liter bottle on this side, a 2-liter bottle on this side. But I'm only going to give you guys, they're going to give me 500, right? 500, 2 lungs, so now I'm getting a whole 250 on each side, right, of my 2-liter capacity. So 1/8, I'm giving you 1/8 of what you could have in each lung. So if I don't do anything to tidal volume, I continue to give you that 500 tidal volume into now the right lung, because I've occluded the left lung. Now I'm giving you that 500. I'm still only 25% of the capacity. I'm fine. There's no problem. You can leave the tidal volume alone, even if you switch it to pressure control. So say you switch to pressure control and you want to maintain your pressure control at 24, 25, whatever, right? Doesn't matter. You've got 5 of PEEP on them. You've got 20 of pressure support on them, so you're at 25. And 2 lung ventilation, you're getting roughly 500, 600 tidal volume. If you include one of those conduits that's going to go down and ventilate one of the lungs, you don't have to do anything. Just leave the lung. Because what's the goal? The goal is to maintain normal, right? To maintain normal. If you decrease your minute ventilation, you can't maintain normal if you decrease your minute ventilation. Does that make sense?
Do you have to go up on the respiratory rate for it to compensate for the loss of real estate, so to speak, for CO2 diffusion?
It depends.
Okay.
Some people, yes.
Okay.
Some people, no. Some people have really bad lung disease that's bilateral. It's not a cancer, okay? So many times you're going to do these cases where you're taking out some sort of cancer, where you're taking either a wedge out or a lobe out or even the whole lung out, okay? But for ease sake, we'll say that you're taking a wedge out. So you're doing a wedge resection. There's an area in the lung that has cancer. It's isolated. The other lung is normal. Normal function. It works well. They oxygenate well. They just had something going on that showed up in a chest X-ray somewhere or some incidental finding, and now they're there to get this out. They're going to be fine with their volumes. On the other hand, now you have a patient that has COPD, some kind of chronic lung disease that's bilateral, it affects both lungs. Now that patient becomes much more difficult to manage. Now, if you have a patient that has a good lung, that's the one that you're ventilating, that's very easy to maintain that normal numbers, right? Your oxygen's good, your PaO2 is good, your PaCO2 is good, everything looks fine on a patient that has a healthy lung. Now, if you have somebody that has chronic disease, that becomes much more difficult. You have to do all kinds of techniques to figure that out. You may have to cut a nasal cannula, put that in the side that's occluded, and basically just oxygenate the non-ventilated lung while you're ventilating the good lung or the non-surgical lung. There's all kinds of stuff that you guys can get into that you haven't even seen yet or never even thought about yet. That's ways to do it. And then there's going to be some circumstances where you go, surgeon, stop. My stat is 80, right? I just need to get him up a little bit. I'll give you another 20 minutes, and then I'm going to stop you again, right? Generally, you can bounce them up. FiO2 is going to be the last thing you increase. Some people, it's the first thing they increase because, well, it just makes me feel better to have a stat of 100%. For me, in lung cases, if they're at 86%, 88%, I'm fine with that. I'm fine with that. I'll run them a whole case on 88%. I'm fine with that. They're not in danger. They're not in danger there. You have to keep an eye on their EKG, right? If you start to have EKG changes, clearly there's a problem. Now you have to get their oxygen up. So there's a lot that happens in lung cases. There's a hand over here.
I'm just trying to think about the logistics of a case like that, and so kind of what you touched on. Whenever you switch over from one lung, or from two lungs to one lung, if you can't ventilate the one lung that you have, do you cancel the case, and is the patient already cut?
No, you'll know that well in advance. So
Okay,
what's going to
I'm
happen
just trying to
is,
figure out the sequence.
right, so what happens is, we'll just run through it real quick. So it's going to be a normal induction, all right? Bring the patient on the bed, monitors, induce them, put the tube in. One of the first things you're going to do, even before you turn them, is you may test it. Where you clamp you either clamp the bronchial or tracheal side and you're ventilating your non-surgical lung, right? Can they tolerate it in a supine position? Yes or no? We don't know, so we're going to test. Now, we've done a quick test. We've maybe given them a minute, maybe 2 minutes. The circulator's putting in a Foley. The circulator's doing something. Something's happening in the room. You have a little bit of time. Now we're going to adjust the patient's position because generally those patients are going to be in a lateral position. So what's one of the advantages you have of having a lung isolation technique where you have the dependent lung that's being ventilated?
It's getting perfused.
It's the better perfused lung, right? So now you have your dependent lung, that's the only lung that's being ventilated, and it's the best perfusion area. Many times these cases go okay because you have your best scenario happening. You're only ventilating the dependent lung. That's where the maximum amount of blood flow is. So this is a really good position for you to be in because you're only ventilating the one lung. So if you have them in, let's say we're doing a total hip, and we have a single lumen tube in, now your airways can be a lot different with your VQ mismatch. Because now you're sending most of your volume to your non-dependent lung, but your perfusion's to your dependent lung, right? But on an isolation technique, sometimes you're in a good position because your ventilation's going to the dependent lung.
In that case where you're lateral and you're using a single lumen tube, do people put double lumen tubes in and then just clamp off the one lung to kind of compensate?
No, because that's a huge tube and it's very risky. Yeah, it's a gigantic tube. I mean, when you guys get used to putting in a 7.0 or a 7.5, 7.0 for ladies, it's a woman, 7.0, a man, 7.5. The first time you pull out an 8.0 tube, which was standard in the ICU, you're gonna look at it and go, Jesus, it's a big tube, right? No, it's a standard tube. A woman in ICU has a 7.5 and a man has an 8, sometimes an 8.5, right? Depending on how big they are. We'll put 7.5 for everybody. Well, a double lumen tube is like, it's gigantic. It's gigantic. I can't explain it. You just have to
Number
see.
size compared to an 8.
It's probably 12 or 14.
Garbage.
It's big. Yeah, it's big.
I did put an 8 in somebody the other day because they were gonna leave them intubated and
Yeah.
it was really tight.
Yeah. Yeah, they're bigger tubes. I mean, they're just bigger tubes, but that's standard in ICU, right? In ICU, yeah, it's just, that's generally what happens. So no, like if it's a single lumen tube for somebody that's single
Right.
Or a double lumen tube for, a patient that doesn't need to have long isolation, no, you just have a single lumen tube, just manage it. But you try and get them back, for me, I try and get them back breathing as soon as I can. Because that's better. I'm not in a great position, but I'm better than anesthetized, paralyzed, positive pressure. If I'm giving them positive pressure where they're spontaneously breathing and they're not paralyzed, I'm at least a little better with my mismatch. So you guys will find, I do things based on experience and a lot of reading. I don't re-paralyze patients. Rarely do I re-paralyze patients. When you guys are in the room, get the Beck out. You gotta read. It's time. They gotta twitch. They got one twitch. Two of that right now. One twitch. Holy shit, you got 2 twitches. Jesus, the case is almost over. No, it's okay. If you keep someone appropriately anesthetized, where they're asleep, they are relaxed. They're not gonna fight the surgeon. If you are trying to wake them up while the surgeon is trying to close the abdomen, the surgeon is gonna go really tight down here. Can you give them something to relax? You know what CRNAs do?
Propofol.
Paralytic. We're closing the abdomen. Why are you giving them paralytic? Give them propofol. Give them something to get them deeper, but don't give them more paralytic. So now you're going to have to give them neostigmine, this freaking rat poison stuff, right? Everyone wakes up nauseous. There's drugs. Every drug you give has a side effect. If you can stay away from giving people more drugs, you're in a better position. Every drug you give has a side effect. Right? You have to remember that. And neostigmine is a nasty, nasty drug. When you guys are in the ICU, neostigmine to try and break an SVT or something, neostigmine, Jesus Christ, we got a crash cart around. Where's the This bird's going to hell in a handbasket, man. Oh my God, where's the charge card? Get somebody in here, right?
Absolutely.
Neostigmine and anesthesia, it's in the box. Just give it 5 milligrams. Right? ICU, 1 milligram. Atropine, where is it? Got it in your pocket? That shit ready, man. It's going down. It's going down. Right?
Yeah.
It's so different. Right? It's just so different when you're in the operating room. These drugs all have side effects. You have to remember that. And I don't know how many of you guys have used Sugamidex or seen it yet. It's an amazing drug. It's absolutely amazing drug. Fantastic. I could not believe, the first time I used it, I could not believe my eyes. Patient was weak, they were struggling, Sugamidex, flush. Hello, can you take this tube out? It was like giving somebody Narcan, right? Here's our heroin addict, they're unconscious and vomiting, give them some Narcan, they bolt upright, where's my drug? Took it away, you son of a bitch, right? That's what happens when you give Sugamidex. It's unbelievable. It's so fast, and it is permanent. It's great. Neostigmine, not permanent. They can get weak again later, right? They can get weak again later. So you don't give paralytics at the end of the case because the surgeon's complaining that he's having trouble closing. Just give the patient something to get them deeper. Give them propofol, turn your gas back on or your vapor back on, whatever. Get them deeper. Don't give them, don't paralyze them more. They don't need that, right? There's strategies that you can use.
But sometimes you have to appease the surgeon. I mean, the problem, okay, so we were in this GYN case, and, my CRNA was like, she had 4 out of 4 twitches. It was fine. There was no reason to give her relaxant. She was relaxed. And the surgeon.
0.
No, she had 4 out of 4 twitches.
So she wasn't relaxed.
No, she was physically relaxed. She wasn't in pain. She was, the vital signs were stable. That's what I meant by relaxed. Yeah, but she's not paralyzed. And the surgeon was, down at the bottom and saying, is she relaxed? Is she relaxed? And so.
This is somebody somebody that's intubated under anesthesia. How do you know she's relaxed then?
No, her vital signs were stable. She was out of, she wasn't in pain according to her vital signs and everything like that.
Okay.
Is that what you're asking me?
Yes. But when you say relaxed, that has.
I mean how I'm relaxed. Not like how a patient's relaxed under anesthesia. Different relaxation. Zen. It was too zen. Yeah.
Okay. All right, so what did
Okay,
you,
never
what,
mind.
no, I'm okay with that. I'm asking now, what did you do? So what did you do?
The CRNA was like, just give her some.
What did you
And
give
rolled
her?
his eyes.
How much?
It was a 5-hour case.
Okay. How much rock did you give?
Yeah,
I think it was just like a CC, I don't even remember.
Just
Okay,
10.
milligrams?
Yeah,
yeah.
Okay, and then how much longer in the case did you have to go?
like 3 hours.
Okay, did you redose after that?
I don't know.
Okay.
It was 5 o'clock.
We had a similar scenario where it was probably within half an hour and the surgeon complained and I asked her, should we give her all of you, get something now, just give another 20.
20? With a half an hour to go?
But I think
And I was like, that honestly confusing.
Did you guys reverse with Sigamadex, or did you have to use? Oh, okay.
Because they gave a big lecture the first day we were there about, like, you gotta watch your Sigamadex use, so they're gonna take it away.
Oh, see, in Tampa they're quite liberal. Like, I mean, we were reparalyzing every 20 minutes, another 10, another 20, because you can just take it away. Like, it's magical.
But even with Sigamadex, if there are other options, and the patient wasn't, it's not like the patient. There was another case where the patient literally grabbed the surgeon's rear end. I mean, that was like movement.
That's movement. Well, there's a thousand ways to get that, right? I mean, that's the reality of it. There's no one way. My way is my way, your way, when you guys get done your way, you're gonna work with other people that are like, every time I do this, this is why, every time I do that, this is why. It doesn't mean it's wrong, right? Just, it is what it is. Everyone has a way to get through it, and guess what? Patients wake up, they go pack you, they go home, they're okay, right? So, I wouldn't want to criticize somebody for it. I just know for me, in my practice, some of those would not happen in my room, but that's okay. All right, so real quick here, just finish up this one long ventilation. So it says use large tidal volumes. Basically what that's saying is you're not changing your tidal volumes, right? So whatever your tidal volume was set to is what you're going to remain it at. If you choose to use pressure support ventilation, that's fine. All right, so just keep the pressure there. As long as you're maintaining your PaCO2, your end-tidal CO2, your PaO2, everything's kind of in a normal range, it's fine. All right, so there's different ways to get through it. Sometimes your compliance can be reduced, which can increase your peak airway pressure, your peak inspiratory pressure. That's normal, okay? You're pushing the same amount of volume into a smaller space. Because you're pushing the same amount of volume into a smaller space, sometimes you can have increased pressure, such as things. Or it may take more pressure to get to the same volume. All right, that's normal. Management during, basically what this is telling us is these are strategies. So you want to decrease your shunt and minimize atelectasis. Obviously, that's the case. So if you're ventilating a lung and you have the ventilated lung has 100% FiO2 on it, you're going to be increasing your atelectasis there. So you may need to do recruiting breaths a little bit more frequently. Because some patients have bad lung disease and you can't keep them close to 90 on their SpO2 because they just have bad lung disease. So you have to increase your FiO2, right? So that's normal. But if you do that, you just need to understand that you're increasing atelectasis. If you're increasing use of nitrous, you need to understand that's increasing atelectasis. It's okay to do that, you just need to understand the consequences of doing that. Check tube position and suction as needed. So what that's basically saying is, when you have one lung ventilation going on, you can have where you have like a leak where you're pushing volume into the dependent lung, and the surgeon's complaining that the lung is moving. That can happen. All right, because either the tube has backed out some, and you're getting crossover down at the kind of the carina where the bronchial cuff is, and you have some leak across. That can happen. So you need to put your bronchoscope back in, look at it. You may have to advance it, deflate the cuff, re-advance the tube, re-inflate the cuff, verify that it's in good position, and then kind of start back over. the patient's in a kind of a lateral position, the surgeon's kind of pulling and yanking and kind of moving the body around. A lot of times they're on bean bags, so they do have some ability to move. It can kind of make your tube kind of come out a little bit, right? So taping it's really important. If you start to have a little bit of a leak or you're decreasing your tidal volumes, verify that your tube hasn't moved on you. PEEP. So PEEP is something that's good if you can get it. If you can have it on the case. Depending on what's going on, you may or may not be able to put PEEP on the patient, right? Because if you think about COPD patients, which is a lot of these patients that are having lung surgery have lung disease, what happens? They can't get air in or out. Out, right? They can't get air out. So if you put a lot of PEEP on them, now they're breathing against even more resistance, okay? So in those cases, maybe you can't give them PEEP, right? So every case has its own sort of little obstacle that you have to run through and hurdle to jump over. You need to look at what's going on with that patient, decide what your anesthesia is based on what the patient's doing for you, all right? So apneic oxygenation, this is what I was talking about with the non-ventilated lung, where you take basically a nasal cannula, you hook it up, and you put it into the double lumen tube on the non-ventilated side, and you are basically just trying to blow oxygen in there, into that lung. You're not ventilating it, you're not giving it a huge volume, you're just putting some oxygen down there. Now, if you're putting a huge minute, like liters per minute, right? So if you're doing 6 liters per minute through a nasal cannula, it's going to blow up like a balloon. That's not going to work. All right, so it's maybe just for short amount of time, every 10 or 15 minutes, you do it for a minute or two, you get a little oxygen in there. Basically, it goes into the tissue, it absorbs that. Once that's gone, you give it a little more. Sometimes you do it as a continuous thing. It depends on what you can get away with. Some lungs move more than others. If they have real bad COPD, emphysema with big lungs that don't really collapse, you get away with getting a little bit more in there because the lungs are really not moving because it's stiff to begin with. CPAP, yes and no, depends on if it's going to move the lung that the surgeon is operating on. Reinflate, so when you reinflate, this is really important. So when you go from 1 lung ventilation back to 2 lung ventilation, you are going to take the patient off the ventilator. You're going to close your APL valve. You're going to make sure that your bag is full. And when you squeeze that bag to get it to 30, you are not doing that aggressively. It's a nice slow squeeze to get it up to 30. If you are really aggressive, even if you're not really aggressive, and the suture pops off, guess who gets blamed for the suture popping off? Not the surgeon, not the guy who tied the knot, you do. You get blamed for it. You were really aggressive, you blew the knot off, you created this problem. You didn't have anything to do with it. So, keep yourself out of trouble, close the APL, slow, squeeze the bag, slow. That pressure should be building this way, not this way. Slow, up to 30, maintain it at 30, hold it about 10 seconds, the surgeon will tell you when he wants you to stop. All right, because what he's looking for is a leak in his suture line. So be really careful, don't be aggressive when you reinflate. Have surgeon clamp the non-ventilated lung or PA go on bypass, that's if you're getting to an issue. As far as you have bleeding and you need to actually go on bypass. Hopefully you don't have to. So waking people up when you come from 2 lung ventilation. So you want to reinflate the lung, 30 centimeters of water, check the leak. Surgeon's generally going to insert a chest tube on any open chest case. It's going to move the chest tube in, that's good for us. Increase the chance of post-op issue with the pneumo. Patients extubated OR, or you can exchange it, the double lumen for a single lumen tube, take them out and take them to either the unit or recovery, and then the plan is to extubate later. Most cases that I've seen is the patient goes in with a double lumen tube, they are moved back to supine, they're extubated, they're taken to PAC. I cannot tell you that I've seen where we remove a double lumen tube and replace it with a single lumen tube and take them someplace else. Generally, you're trying to get them extubated. The longer they're intubated, the less less likely you're gonna get an extubator, the longer it may take you to get an extubator. So you wanna get an extubator as soon as possible. Chest tubes, water seal, that's fine, patient transfer. All right. So trauma, this is with positioning the tube. Because it's a big tube, you can create problems for yourself, right? So you gotta be careful with teeth, you have to be careful with soft tissue, especially the vocal cords. Really need to be careful. You put that tube in, as soon as you feel resistance, stop pushing it. If you feel resistance with a double lumen tube, stop pushing it, all right? Put the bronchoscope in, look and see where you're at. Make sure you're not hung up on something. Maybe there's a mass we don't know about that's in the trachea that you're caught up on, and now you push through it, now you've sheared something off. You got all kinds of blood in there. I've heard of that happening, that's why I'm bringing that up. That's a bad day. Okay, so don't do that. Get resistance, stop pushing, take a look. Malposition, again, that's for pushing it too far. Hypoxemia, aspiration, all those are risks anytime you debate somebody. Key concepts, you guys can read through that. I think that's it. That was a long talk. I apologize. That was almost 2 hours.